Hello, welcome back to Microbio. Today we're going to be focusing on the viruses that cause respiratory diseases. So first, the Picornaviridae are going to be the smallest, not the very, very smallest, but they are quite small. They are naked icosahedral viruses, so they are not enveloped, and they have a positive sense single-stranded RNA genome. With the positive sense, they are able to make their own. The positive sense is able to be the messenger RNA, and from there, it's able to attach to the host ribosomes and make the structural proteins before it's translated into the negative sense. Before it's translated into the negative sense strand. So it's always back and forth, right? So if it starts with the positive sense, it has to be translated into the negative sense, and then from there, the positive sense again, in order to replicate, more mini viruses. So they are really resistant to detergents, and they are the rhinoviruses, the enteroviruses, along with the Coxsackie, the polio, echo, and hepatitis A viruses. They enter the cell via viropexin or endocytosis. The viropexin is like a needle that they kind of puncture and then get injected into the host cell. So because they are positive sense, they replicate in the cytoplasm, and they don't carry the machinery, so they don't carry the RNA-dependent RNA polymerase, but they code for it. So the reservoirs are going to be in humans along with the great apes, and they mostly infect children during the school season. They're transmitted via direct contact, inhalation, and contact with the fomites. They usually replicate in the nose, and they bind to the ICAM1, and there isn't required for many of them to start the disease, so they have a very low infectious dose. So once they bind to the host cell, the infected cells release histamine and bradykinin, and they are going to replicate best in cooler temperatures, so they prefer the upper respiratory tract. They're acid labile, so they are not involved in the GI at all, and they just cause the common cold. There isn't really any treatment for it besides relieving the symptoms. So here they are either injected in via the viropexin or they are endocytosed. And then they uncoat, then they are translated to the protein, and then it becomes the negative sense. Then it's converted to the positive sense in order for the virion to be, made. Okay, so Coronaviridae, important subject, especially for us now. They have the glycoprotein spikes, which is the spike protein, the M protein, the hemagglutinin esterase protein, the nucleoprotein, and those will all play a role in, either attachment to the host cell, or they have antigenic variability. So that's how the different forms are made. They are enveloped, and they are a helical virus. So they are the longest positive sense single-stranded RNA. They replicate in the cytoplasm. They don't carry the equipment, so they code for the RNA-dependent RNA polymerase, once again, because they are positive sense. And the envelope is retrieved from the host endoplasmic reticulum. So the pathogenesis, they come in via either fusion or endocytosis, and then the L protein is going to be made in order to make the negative sense template. So it's converted from positive into negative. The structural proteins are going to be making the nucleocapsid, and they are released by exocytosis. So the most serious forms we need to be concerned about are the SARS-CoV, the MERS-CoV, and right now, coronavirus, which is SARS-CoV-2. These are the beta genus viruses, and the reservoir are kind of different. Usually they're just humans, but in the SARS-CoV, and they come from bats, cats, raccoons, and dogs. MERS come from bats and camels, and the SARS-CoV-2, we're still unsure about it. They are transmitted via droplets, except for MERS-CoV. It's actually from drinking camel milk or eating camel meat. The conventional coronavirus is only limited to the upper respiratory tract and cause common cold symptoms. But the more serious forms will infect and kill the alveolar cells, so that causes the systemic hyperinflammation, and from there it can lead to a lot of really serious complications such as DIC. So the MERS-CoV will infect the non-ciliated bronchial epithelial cells, and that's problematic because without the cilia, it's not able to move the virus along and get coughed up or sneezed out of the body. The SARS would be the form of the atypical pneumonia, so high fever, chills, dyspnea. MERS is much more severe, and the incubation period is 5 days. It's about 5 days for everything, 2 to 7 days. 5 days is about average. But the difficulty breathing does set in around day 5, and then that can advance into ARDS, renal failure, and then from there, of course, multi-organ failure and death. Okay, so COVID, we're still figuring this out. There's a wide range of symptoms from some people just say, oh, I just felt kind of yucky for a couple days, but now I'm good. And then some people go into full DIC and multi-organ failure. There are some speculations that people with underlying illnesses such as, COPD, diabetes, metabolic syndrome, of course, these people are more susceptible to getting a hyperinflammatory phase, but we are still conducting a lot of research about this. What we do know is that in the more severe cases would be pneumonia, ARDS, and septic shock. There is some ways that we can diagnose using the rapid test, PCR, ELISA. There is no specific medication. You hear a lot of people throwing around words like hydroxychloroquine or ivermectin, but there is no true basis for why to use these, right? Here in the States, they're not FDA approved. I know that there's been some anecdotal or very, very mild reports of these medications somewhat working, but they're generally done in India where they have less access to the ventilators, ECMO machines here in the States, in the developed country. So they are kind of throwing everything at the wall and seeing what sticks. I've read a couple papers on it, but it doesn't seem like there is a robust enough study to even really consider this. It's not ethical to, test on people here in the States. We haven't even gotten to that part of clinical trials and whatnot yet. This is all speculation. So I highly don't recommend using any of the medications that the FDA has not been approving things for. There are pretty severe side effects, especially if you use hydroxychloroquine or ivermectin for too long. So yeah, medications are approved for certain illnesses for a reason. However, the FDA has granted remdesivir for emergency use. This is going to be an antiviral. It prevents the docking of the COVID into the cells. But the problem is generally by the time the patient comes in and presents with the symptoms, it's already too late. The cell has already been infected. What's there to stop it? This can be used more for prophylaxis if a physician is going to India, maybe for a medical mission trying to help them. But Yeah, it's not super useful for a patient who already has COVID. The other problem is it's also very, very, very expensive. So, what can we do? Maintaining hygiene, washing hands, wearing your mask, and the vaccine. The vaccine is quite safe. It's an mRNA. It does not affect the host genome. It will only, affect the virus. Like it teaches us our cells, like, what to avoid, what to look for. So we're going to look for these spikes on the COVID, or we're going to look for the viral DNA, but it does not actually change the host DNA. So the adenoviruses are going to be your naked icosahedral double-stranded DNA virus. This one's a little bit special because it's it's a pentamer, and the capsid proteins would be the hexons and the pentons. So the pentons are going to be your long ones, and they act like the hemagglutinin to attach to the host cells. They resist the drought, detergent, and mild chlorine. So you have to hyperchlorinate some, like swimming pools and hot tubs. They have some common receptors with like other viruses, such as the Coxsackie virus, also CD46, MHC1, integrin, and sialic acid. So using that, they have the receptor-mediated endocytosis. So our cells will recognize it, think it's normal, and then absorb the virus. So there's a semi-conservative replication going on in the nucleus because it is a DNA virus. So the reservoir is humans, and it's transmitted via like coughing, sneezing, fecal-oral route as well. Risk would be crowded living areas, patients who live in dorms, patients who are living in the barracks and the military, and swimming pools. These adenovirus are lytic viruses, so they kill the cell once they are mature. And in some cases, they have a latent infection, so they can go into the non-permissive cells and stay in there and then cause reoccurrence once the immunocompromised patients, cells are a little bit weaker. So if the immune system is down, it comes back. And they can cause cancer, but it's not seen in any humans. It's only in hamsters. The disease is going to be determined by the tissue type of the specific serotype. So it can either be lytic or it can be latent. So they avoid the immune system by inhibiting the interferon response. They block the apoptosis of infected cells, and they reduce the MHC1 expression. So they don't allow the cell to die, and they stop the call for help. They bind to the P10-5RB and P53, so that prevents the cells from dying. And they cause the pharyngitis, the pharyngoconjunctival fever, which is an infection of the pharynx and the conjunctiva. They also cause the acute respiratory disease, pneumonia, diarrhea, hemorrhagic cystitis. But usually they just present as like the common cold, inflamed pharynx. It's associated with the poorly chlorinated swimming pools. So once again, got to hyperchlorinate things. And ARDS is going to be caused by the serotype 4, 7, and 21. This is a little bit more rare, like it's not as common, but still important to pay attention to. You rarely just diagnose them via the clinical presentation, but if you want to be absolutely sure it's a adenovirus, you can do the antigen detection, immunoassay, PCR. There is no specific antiviral therapy. It's really just to be prevented and just maintain the symptoms, because once again, it's usually just like pink eye or it's pharyngitis. So the Coxsackie virus is it's a Picornaviridae and an enterovirus. So it comes from the intestines. There are two types A and B. A causes the hand-foot-mouth disease. It's really common in children, like super, super, super common in children. And B, this one can cause the myocarditis, that should be myocarditis, and pericarditis. In general, it presents with like common cold symptoms, but in severe cases, especially in children, it can cause meningitis. So it's a naked positive sense single-stranded RNA. The reservoir is human, and the transmission is the fecal-oral route. That's the hand, foot, mouth disease, droplets, and fomites. So Coxsackie A is also known as hepangina and vesicular pharyngitis, where there is going to be almost herpes-like lesions on generally the children. So it looks like all this like red spots. There you go. The vesicles are kind of large. That's why they're not considered like herpes, but it's herpes-like. They have fluid. They're generally 1 centimeter in diameter, and the kids present with like a sudden fever, sore throat, this vesicular rash inside the mouth, ulceration of the skin. There can be a PCR test done, but generally it's diagnosed via the clinical presentation. So it's going to be self-limiting. You treat the symptoms, you treat the sore throat, you treat the fever, but remember, since it's generally children, you don't give them aspirin, and it's a virus, so definitely don't be giving them aspirin. It can progress into Ray's syndrome. You want to really like prevent the sores from erupting or bursting, and that can cause a different kind of infection. So you want to put like Neosporin on top of the lesion so it doesn't itch either. Kind of cover it up with band-aids too, because kids will scratch relentlessly. So you want to treat the fever, you want to treat the rash, and you want to just like, help them maintain hygiene and drink water. So unfortunately, there is no vaccine. Hygiene is pretty important. So get these kids to wash their hands. Like give them a bath after school or after pre-K, especially after they've been playing in the sandbox. Okay, herpes. It's part of the Herpes Viridae gamma virus family, and it's a large, enveloped, linear double-stranded DNA virus. So, of course, we all know they are pretty latent, so they can come back anytime they want to, especially when you are stressed. Herpes alpha was going to infect the epithelial cells, so that's going to really present as your herpes simplex 1. That's the cold sores. Herpes simplex 2, the genital sores, or genital herpes, and varicella zoster, which is chickenpox or shingles in adults. The beta herpes virus is going to infect the lymphoid cells instead. Cytomegalovirus is also in the herpes family, so it's human herpes virus 5. The herpes lymphotropic virus is going to be HH6 and 7. And then the gamma herpes virus is the most serious one because this can cause cancer. That's going to be your Epstein-Barr virus, your Kaposi sarcoma virus, and those are going to be HHV4 and HHV8. So 4 and 8, those are the problematic ones. 1, 2, and 3 is the most common ones. Okay, so they replicate in the DNA because they are They replicate in the nucleus because they are DNA viruses. They infect the CNS, actually, so that's how they live in the nerves. Epstein-Barr virus is an enveloped double-stranded DNA virus that is linear. It can have several different forms. So the endemic form, it causes Burkitt's lymphoma. It can also cause mono, and the risk factors is, of course, like sexually mature adults. It sheds through the saliva. It's a lifelong infection. But if you're infected as like babies or very young children, you get lifelong immunity. It infects the epithelial cells and the B lymphocytes. And they work by attaching to the host cells using GP350, and that binds through the complement. So with the complement, it prevents complement activation, so they're not eliminated from the body. Let's see. The permissive or productive type of infection is when the virus replicates and lyses the infected cell, and that's usually mono. The incubation period is about like 4 to 6 weeks, so it can be about 4 to 6 weeks after infection before you start showing the symptoms, which the triad is going to be the exudative pharyngitis, lymphadenopathy, and splenomegaly. So the splenomegaly is the most concerning feature there. There's a presentation of a high fever and fatigue that lasts about 1 to 4 weeks. When you test the patient's blood, there's going to be heterophile antibody positive, which is just like a non-specific antibody that's raised. You have to do a little bit more testing to be specific, but there's a good indicator that, hey, something's wrong here. The chronic infection is going to be cyclic, recurrent disease, of course, and that's usually in the permissive or latent type of infection. So because it's a DNA virus, it can remain in the nucleus and not get integrated until there is a signal that shows like, hey, immune system is down, time to replicate. So in the non-permissive cells, that's going to cause the Hodgkin's lymphoma, and that's generally in patients with a T cell deficiency. It also presents as a nasopharyngeal carcinoma, which is endemic of Asia, and that's going to be the cancer of the epithelioid cells. In AIDS patient, it's going to present as oral hairy leukoplasia, especially on the tongue, like right here. And there's going to be multiplication also in the epithelial cell. So the other test that I said, the heterophile antibody positive, like since that's pretty non-specific, it's a good warning. Now, to be more specific, you want to see if there's lymphocytosis, and in particular, the Downey cells. You can also use the monospot test for a quick test, and then move on to the specific antibody test against IgM. So you treat the symptoms, you can give steroids to reduce inflammation and treat your rash. But in general, if you get like Hodgkin's or Burkitt's lymphoma, you want like high dose chemotherapy, and it generally responds really well to those treatments. Okay, so the parainfluenza virus is part of the Paramyxoviridae family. It also has spikes, kind of like the coronavirus. And there are H, N, and F spikes that stand for hemagglutinin, neuraminidase, and fusion. It's an enveloped helical virus with a capsid, and that contains a negative sense single-stranded RNA. So since it's negative sense, it carries the equipment with it, so it carries your RNA-dependent RNA polymerase. The paramyxovirus can cause parainfluenza and the mumps. The pneumovirus generally is the respiratory syncytial virus, along with the metapneumovirus, and the morbillivirus is going to cause measles. It replicates in the cytoplasm, buds, and they can cause both lower respiratory tract infection and upper respiratory tract infection. It's transmitted by droplets. There's not really any long-term immunity, unfortunately, so you can get it like multiple times. The hemagglutinin binds the sialic acid, and it forms the giant cell, and that causes the cell lysis once they have budded. The F protein fuses the cells together to make the syncytia, and the neuraminidase will allow the budding and the lysis to occur. So this is going to cause croup, the bronchiolitis, and pneumonia. Croup is going to be really defined by this barking cough, where there's like a sharp intake and all of a sudden like very like short barking coughs, thanks to the swelling of the airway and the inspiratory stridor. But symptoms, once again, worsen laying down. Do an x-ray, you see a steeple sign. Unfortunately, there is no vaccine, and reinfections are really common. The respiratory syncytial virus has no hemagglutinin or neuraminidase, but it's still enveloped. It's a negative sense single-stranded RNA virus, so once again, it's going to replicate in the cytoplasm. They do have the F proteins though, and that helps form the syncytia. Subtype A has the more severe clinical illnesses, and unfortunately, it's the more common cause of the outbreaks. Subtype B is asymptomatic. The reservoirs are only humans, and it's transmitted via droplets. So cover your mouth, cover your nose when you sneeze. It affects children, adults, immunocompromised patients. It can cause bronchiolitis and pneumonia in babies, and is the most common cause of the acute fatal respiratory tract infection in newborns. So they bind to CX3 in the epithelial cell to make the syncytia, and then immunologically mediated cell injury occurs. Cytokines are going to be released. Necrosis and sloughing of the epithelium is going to occur, and that forms the plugs, the mucus, the fibrin, and the necrotic tissue that obstructs the air pathway. It starts really mild, like just cold symptoms, and then progresses to pneumonia. Then you're going to see the dyspnea, the rales, fever, chest retractions during breath. Then you're going to diagnose using a rapid test PCR or reverse transcriptase PCR, ELISA, and the cell culture. You give the bronchodilators, oxygen therapy, and ribavirin to interfere with the viral replication, or Respigam. You want to use an immunoprophylaxis for children with chronic lung disease or congenital heart disease. So you give them the palivizumab and Respigam. This is going to be your monoclonal antibody. Metapneumovirus is a Paramyxoviridae pneumovirus, and it's going to be an enveloped single-stranded negative sense RNA virus. The glycoprotein is going to bind to the heparin sulfate and other glycosaminoglycan, and that's going to bind to the cell and allow it to be enveloped. It has a fusion protein, so it's going to form syncytia, and it generally affects children, the elderly, and the immunocompromised. So it can cause, once again, like mild things like a cold, all the way to a more severe illness like pneumonia. The influenza virus, there's actually several families of them, and they are the most common cause of the respiratory tract infection. They are, in general, an enveloped helical virus with a capsid, and it's a single-stranded negative sense RNA. So the spikes are going to contain hemagglutinin and neuroamidase, and they have a matrix protein to uncoat the viral DNA. It's a negative sense virus. It carries RNA-dependent RNA polymerase, and there are types A through D, and that's going to be based on the variation of the matrix protein and the nucleocapsid proteins. But in general, A and B causes the illnesses. Influenza A has 18 different kind of subtypes and 11 neuroamidase subtypes. The most common ones that we got to be concerned about is H1N1, swine flu, and H3N2, which is avian flu. A and B can cause pandemics, but A can cause the pandemic. Transmission, droplets, fomites, risk factors, as per usual, elderly and children. There's agglutination antibodies to prevent binding. The neuroamidase is going to allow the release of the viral progeny and dissolve the mucus layer. So this is going to cause the runny nose. The antibodies are going to be produced to prevent the release and spread of the virus. Okay, so what's particular about the influenza virus is that it steals the cap of the host cell. So it takes the methylated cap region and uses it to replicate inside the cytoplasm. It gets our envelope from our cell membrane, and it can go through a lot of very quick mutations. That's why it's kind of hard to make a vaccine against the influenza virus. So antigenic shift is a dramatic change. There's a reassortment, and it's more common in the segmented virus. The point mutations are going to be in like all forms of the virus, and it's slow and it's gradual, and it's responsible for the seasonal types. Okay, so generally it's self-limiting, but you can get secondary infection. Ray's syndrome, of course, you have to be careful about that. Diagnosis is generally the antigen detective, reverse transcriptase PCR testing, hemagglutination inhibition assay. And the treatment, okay, so if you catch it really fast, you can be given the neuroamidase inhibitors, which are oseltamivir, which is your Tamiflu, zanamivir, or you are given amantadine and rimantadine to block the matrix proteins. Unfortunately, that's only effective against the type A. So these are the difference between the flu or COVID. These medications are still like pretty expensive too, even with copay. I think the midwife's treatment is to feed a fever. So lots of like liquids, and actually a lot of zinc. Zinc does help with the flu. Luckily enough, we get the vaccine. There's the flu shot. It's an inactivated virus with a mixture of all the strains. It's also a recombinant vaccine where you can insert the gene encoding the hemagglutinin into an insect virus, and then the hemagglutinin protein is harvested, and then that's put into the vaccine for humans. So it's not actually infecting like human cells. You can also do the live attenuated influenza vaccine, which is made from a mutant strain and the virulent strain by reassortment. And it's a cold adapted mutant. So technically it's alive, but since it's been genetically modified, it's not going to cause illness in the patient. The illnesses that come from vaccine is actually host response. Okay, that's it for now. Thank you for your attention, and good luck studying.